afternoon, everyone. It's noon. Why don't we get started? Welcome to today's Public Health Ontario Rounds presentation on eCOVID19 RecMap and Gateway to Contextualization, Finding and Using Evidence on COVID-19 in Public Health. My name is Yasmin Khan, and I'm a physician lead in health protection at Public Health Ontario, and I have the pleasure of moderating today's session. As we begin today's rounds, we wish to acknowledge the lands and waters of the traditional unceded and treaty Indigenous territories on which Public Health Ontario operates. We respect and appreciate Ontario is now home to many diverse First Nations, Inuit, Métis, and urban Indigenous peoples and cultures. We are grateful to have the opportunity to work on this land for the mutual benefit of all. I'll now mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And I would like to state that as the moderator, I do not have any conflicts of interest. It is now my pleasure to introduce the speaker for today's presentation, Dr. Thomas Pigott. Dr. Thomas Pigott is the Medical Officer of Health and CEO of Peterborough Public Health. Prior to this role, he was an MOH with Labrador Grenfell Health and a field doctor with Médecins Sans Frontières in the Democratic Republic of the Congo. Dr. Pigott is a public health and preventive medicine specialist and a practicing family physician, actively involved in research and teaching in public health at McMaster University and Queen's University. Dr. Pigott's research work has focused on guideline development and health equity. He has advised on public health guideline development methodology for multiple organizations, including the WHO and the European Commission. And with that, I'll turn it over to Dr. Pigott.
Thank you so much for the invitation to speak here today. Thanks for the intro, Dr. Khan, and really looking forward to the session today, but also hopefully some good discussion and some questions and thinking. I want to acknowledge today is actually World Evidence-Based Healthcare Day, so quite fitting. And if you're interested in joining on social media, hashtag World EBHC Day, you can see a little bit about what others are talking about in the realm of evidence-based decision-making, which is fitting, because I'm going to talk to you today about evidence-based recommendations for COVID-19 and a really exciting project that I've been fortunate enough to be part of around a recommendations map for that work. So I'm going to continue and just show my initial declarations of interest slide. So I do just want to acknowledge that I'm calling in today from Treaty 20 Mississauga or Mississauga Anishinaabeg territory here in Peterborough, and that Peterborough Public Health serves Curve Lake First Nation and Hiawatha First Nation in our region. Of note too, you can see my lens, personal background lens and privileged perspectives I perhaps bring to some of these conversations and intellectual interests. But to note, I have no financial interests or conflicts of interest to declare. So today I wanted to chat and share a little bit about the role of guideline development and how guidance has evolved through the COVID-19 pandemic to provide colleagues in public health here in Ontario and perhaps elsewhere and other stakeholders and intro to this large, several year now, more than 2 year now, eCOVID RecMap project with partners from around the world. We're going to talk a little bit about identifying recommendations that are critically appraised and how they could be perhaps used through the RecMap to contextualize and implement guidance. And finally, I'm going to share some early thoughts around how it could perhaps be used more effectively by public health units locally, using some examples here from our own health unit. So I just wanted to start by sharing some thoughts around how science and evidence has evolved in the last, it's crazy, I keep saying nearly 3 years of the pandemic, because of course in January we're coming up on 3 years of COVID-19. So first and foremost, I think we need to acknowledge that science and guidance based on it has moved at an unprecedented rate. And with this, there's been tremendous international collaboration, especially in some fields. Some of the trials for medicines, et cetera. There's been global collaborative work on research that I think has been tremendously impressive. However, at the same time, I think a really important finding is that there are significant duplications of work, especially around evidence synthesis, the work around systematic reviews, guidance, and the recommendations that flow from. And with all of this, with both the duplication of work, sometimes it doesn't lead to the same conclusions, and the unprecedented rate, I think this pace has challenged health decision makers in new ways, new challenging ways. Further complicating this is the deluge of misinformation, what WHO Director General Dr. Tedros deemed an infodemic, an online social media fueled infodemic that's spread as fast or faster than the pandemic itself. And I think in this, what we've seen, especially more recently in 2022, is increasing disagreement, changing guidance, and eroded public trust that I think is going to challenge us beyond the COVID-19 pandemic. In addition to the public, I think for practitioners, including public health practitioners, it's really confused and even bewildered us. What does the science, quote unquote, the science say? What is evidence around particular issues? And at the end of it, I worry that we are left not more prepared in the continued evolution of the COVID-19 pandemic and for future threats. So I just wanted to start with some of those reflections and thoughts, and I'm going to go into explaining some of this a little bit more and how I think the eCOVID RecMap project can be helpful in this. So here's a chart just showing on the right journal articles up until late 2020 on COVID-19 publications, and you can see the massive exponential growth in papers and preprints on the subject. On the left, you can see how quickly from time where the pathogen was identified to the year when the vaccine was licensed. And we know this, but just putting it in perspective with this Nature article, I think is fascinating, because SARS-CoV-2, the time from identification to licensed vaccine was remarkably quick, less than a year, and really has been unprecedented. So with this massive explosion of journal articles, preprints, and primary evidence out there, I think an increasing challenge has been with synthesizing this evidence. So you can see broadly, not just on COVID-19, health science systematic reviews have exploded at an exponential rate. And so knowing what to make of synthesized evidence, not just primary evidence, is really challenging. I want to talk a little bit about some of the work that has come out in the recent Global Commission on Evidence to address societal challenges, because I think it's a fascinating look, if you haven't read about it, at how evidence has been used by decision makers. And you can see their conclusion that single studies, expert opinions, expert panels, jurisdictional scans often informed these rapid evolving, rapid paced decisions much more than the best evidence that was perhaps available, and using evidence such as evidence synthesis strategies, systematic reviews, and guidelines on different topics. And so what do we do about this, and where has using the best evidence worked well, and where has perhaps the pandemic been more challenging? I think public health has had a bit of both. An example of where I think the best evidence has been working tremendously well is in the impressive work that NACI has led for the country on synthesizing evidence and making evidence-based recommendations on vaccines. And they use systematic processes and methods, which I think have really helped the quality of their guidance, and where they have made complicated decisions, think dose interval increases or other indications that were not directly on vaccine authorizations, I think that NACI has done a tremendous job of actually getting it right in their systematic evidence-based approach. But a lot of other guidance, and I won't name particular fields, but a lot of other guidance in the clinical realm and certainly in the public health realm, I think has fallen victim to what we often call in the guideline world, good old boys, and it's not just boys anymore, though it certainly used to be, sitting around a table. And this GOBSAT approach is one where evidence is not systematically assessed and is not necessarily linked to the final recommendations that come forward. Instead, prominent experts, perhaps people with big faculty positions or large social media following, sit around the table and dictate the guidance that comes out at the end of the day, which I think has been for the COVID-19 pandemic problematic. So I want to introduce you to the GRADE working group. Many of you will know about GRADE, but GRADE came about to address this exact GOBSAT related challenge and to try to create a systematic and transparent process where the evidence could be assessed, the certainty of that evidence could be assessed, and recommendations could be made that are sensible and transparent on that basis. So grades used, and I did in my intellectual interest disclose I am a member of the GRADE working group, and I certainly think there's a lot that it can bring to discussions, including public health guidance related discussions. So GRADE came about to address this challenge and this issue. And I think where guidance has used GRADE, there has been a more rigorous inclusion of evidence and perhaps better evidence-based decisions made at the end of the day. We talk a lot in the medical world about doing no harm, and I think it's a little bit more complicated than just that, because what we have to look at is the balance, and in GRADE we often talk about doing no net harm, because any intervention may come with some harms. And what's most important is really thinking about the balance at the end of the day between an intervention and its benefits and the potential consequences. And if we think back to the pandemic, I think there's been a lot of areas where we've seen polarization and kind of dichotomous thinking around issues, when in reality, perhaps science is a little bit more ambiguous than that, and the certainty isn't as clear. And I think where we have changed positions on some of these dichotomies, it has led to further erosion of public trust and has been challenging, problematic, because perhaps we weren't as true as we could have been to some of the ambiguity in the first place. And so I think that this is an area where thinking through GRADE and GRADE's approach and guidance could be quite helpful to public health. So what does the GRADE assessment involve? I mentioned before, it involves separating out the strength of a recommendation and the certainty of the evidence that it's based on. So here's a cartoon we sometimes like to use. I figure there's a 40% chance of showers and a 10% chance we know what we're talking about. And in GRADE, there's a differentiation between conditional and strong recommendations. The certainty of the evidence, on the other hand, is a separate factor. And even if we have a strong recommendation for a really good rationale around something, separating out the certainty is important to being truthful to it. And especially if the evidence changes, I think having that certainty and having the public aware that we still aren't as confident perhaps in the certainty as we thought, I think is really critical, and something that we could have done a better job of through the response to the public health pandemic. The other thing GRADE does is recognize it's not just about the evidence on the benefits of the harms of something like a new vaccine. It's also about a whole number of other criteria, and these are referred to as the evidence to decision criteria. And this is one framework. There are some others, but the ETD framework says, in addition to talking about the benefits and harms, to get to what recommendation we're making, we need to think about a whole confluence of other variables, things like values, resources required, cost effectiveness, equity, acceptability, feasibility. And these variables really have an important weight and influence in the recommendation that's made at the end of the day. So why is this all important? Empirically, when we've looked at evidence that's been integrated into the RecMap, which I'll be speaking about shortly, one of the big challenges we found is with diverging recommendations, where two different groups come to different conclusions. Some of that may be natural, but I think some of it is in methods and process. And as a result of a lack of transparency in how the recommendation was developed, I think the public is rightfully left more confused as to why the same body of evidence can be interpreted differently by different groups. Context is certainly important, but I think clarity on some of these criteria, again, back to this ETD framework and these kinds of criteria, is critical in order to convince the public of recommendations in a more trustworthy, transparent way. So I am going to introduce now the Living Recommendations Map. And this was created because of that challenge of the explosion of systematic reviews and guidelines recommending all kinds of different things for the COVID-19 pandemic. We'll look at the numbers here shortly, but needless to say, there's been a ton of guidance that has come out. And what we wanted to do was to create a tool that was easy to navigate, that was living, recognizing that evidence changes very quickly on different topics, that was freely accessible, that was available worldwide in an electronic platform, and that included not only all available evidence, but appraisal on how rigorous and trustworthy that evidence is based on critical appraisal of that recommendation. The notion of a recommendations map or a RecMap evolved prior to the pandemic, but really fit well with COVID-19. And so the first one that was developed was for the WHO TB guidelines, and all of the recommendations from WHO on TB were mapped out. I'll talk about what that means here shortly. But the interesting thing is there had been, we had done, and it was actually really just recently published, a randomized control trial looking at the traditional approach to guidance, which is usually in a PDF document that you have to kind of scroll down and see what are they saying, what changed. I'm sure many of you will have been through a lot of that in the pandemic. Okay, reconcile these two versions, what changed, versus the RecMap, where by population and intervention, you have some clarity in the presentation. And what we found is that the ETB RecMap was more accessible when compared to conventional website. And we found similar things with our current project, this international collaboration with more than 57 researchers from around the world, more than 19 countries participating. And here's some of the organizations that are collaborators on this project from around the world. So what we have done, and this is the most recent project number update that I have, is extracted the recommendations from guidelines from around the world. We're now at 466 guidelines with 6,763 recommendations extracted. And it's had fairly significant use from across 169 countries and 26,000 users. So again, the volume of guidance in COVID-19 has been tremendous, but we've been able to extract quite a lot. So just to highlight some of the work that's been undergoing, we've now retired a number of guidelines. 285 have been retired because they're no longer up to date. And we've also done work to support contextualization in different countries and this notion of developing plain language recommendations, because sometimes the recommendations in evidence is written in a very technical sort of way that is not readable to the public. So we've been doing work, and there's 54 plain language recs, at least maybe more now, onto the RecMap, where the language has gone through a rigorous process. I'll talk about the plain language rec piece shortly, and there's been quite a lot of really interesting academic work that has come out of this work as well. One of the knowledge mobilization projects is around public health in the Ontario context, and that's something that I'm leading with a couple of health unit and PHO partners, and we're going to look to engage a more focused group for more discussions on how we can improve this as a tool resource that's available in the coming months as well. So what is the RecMap? Let's go through it a little bit. It provides decision makers with this easy to navigate platform where the evidence is all there and has been critically appraised so that it could be used in practice. And certainly it's across a range of clinical, public health, health system related recommendations. How do we get evidence onto the RecMap? Well, we have a large review process that involves support from health science librarians and a number of platforms, including Love and NIPH, and the search is done on a continuous basis, and new hits, new guidance that fits inclusion criteria is identified for assessment, whether it meets inclusion criteria, and then extraction. This all goes into this database behind the scenes that's in this GradePro GDT software that then feeds the front end that you see with the RecMap. So this is a bit on how the search happens, bibliographic on a daily basis, gray literature sources on a monthly basis. We work with a bunch of partners too who directly send new guidance and identify. And then there's a number of key organizations that are reviewed much more closely as well for extraction. The eligibility criteria is that it is a guideline, that it has any kind of new, updated, adapted recommendations, that it's on a COVID-19 topic of some kind. There are no population or language restrictions to this. Then it undergoes a agree to, which is the appraisal tool instrument we have for guidelines on 3 key domains that were assessed as important for the RecMap: scope and purpose, rigor of development, editorial process. And then this is used both to present so that people know what the agree to score is, and also is used in supporting the screening. But there are also key organizations such as WHO, Public Health Agency of Canada, that regardless of screening level, we had been including into the RecMap because people need and go to trusted sources such as those organizations for recommendations. We have an extraction process in the back end where both digitally, manually, there's extraction work done, categorizing this, and then it goes front end into what you can see when you go to the eCOVID RecMap website, which is a searchable database or a list, and the list can be filtered. So on the right, you can see you can filter by source, world region, age group, coexisting condition, intended population, recommendation intent. And there's a few more clinically oriented guidelines you can see popping up here in the list view. And then on the map view, what you get is population down the left in rows and the intervention across the top. And if you click on each of the interventions, say treatment or diagnosis, when you click, there's a drop down and a much more detailed list of sub interventions is provided. And you can see the number that are there for each of these interventions and populations, and you can click on it and then look at that guidance directly. You can also filter on the map itself by source if you're looking for guidance from the Public Health Agency of Canada or from the Canadian context. When you click on the recommendation, a bar on the right shows the grade assessment of the certainty of the evidence and the credibility, the agree to score, again, on the instrument that we critically appraise the guidelines with. You can also see a bunch of other information available, including this interactive summary of findings, the evidence to decision criteria that we're talking about there, some information about important things like conflicts of interest, and if it's available, the plain language versions, etc. So that is all of the information that is available when you click on an individual recommendation on the RecMap. Here's some of the lessons that we've learned in the process so far, just to reflect. So one is that the RecMap and seeing this listing can help to identify some of the gaps where there is little to no guidance in an important topic. It can also help to understand that different audiences, public health, clinicians, et cetera, have different needs at different times, and trying to filter, we've been trying to make it so that it can be helpful. There's been a few spin-off projects for organizations such as WHO and other organizations on specific aspects, so including one just on WHO guidance, if you want to see that. And there's a couple others in the works looking at that for disease conditions or other organizations. And I think one other real key observation is that the challenge of this is maintenance, because there's such ever-changing, fast-paced evolution of guidance. And we've really needed to work hard to update and make sure that it is as up-to-date as possible because the guidance changes so quickly. The other thing we've done is on a weekly basis when we meet, we prioritize different topics, and that's shifted as we've gone through the pandemic. And I'm sure many of you will recall when we were desperate for information on booster doses and Omicron and new treatments or rapid antigen tests and which populations and when they should be used and all of that. So every week through the pandemic, we've been having conversations about the prioritization of different key topics from multiple lenses. Now, one of the challenges is quality guidance development that's based on the methods around grade takes time. So how do we decrease the resources needed or increase the resources investment so we could get better quality guidance in public health, which I think is a really important, beyond the excellent work that I think NACI has done for other public health topics, I think is a really important question. And sometimes beyond just the time and money, there's human resources related challenges. You need the expertise, both in content and also methods. So one of the things that's been really exciting as part of this RecMap is thinking about how existing guidance, work that other people have done to extract and have evidence synthesis, systematic review and guidance done, could be taken from one jurisdiction and looked at in another. So I'm going to introduce you to a new contracted word, development, which stands for adopting, adapting, or developing de novo or new guidance. And it's a framework and process that is usable with the RecMap, so that if you, let's say PHO, wanted to look at a new topic, you could see, has anyone done this work before? And if they have, does it meet the same question, the PICO kind of question that we're trying to address? And if so, is it good for our context, or is there some unique considerations, maybe the epidemiology of the issue or the resources or the political considerations, et cetera, are different here in Ontario? Well, we can take that evidence synthesis because, the interpretation and inclusion of things like trials or studies that was done initially could still be relevant to Ontario, but we could actually take that and recontextualize and look at it in the Ontario context. So this is a process that's facilitated, and you can click if you're interested in this. Many of you certainly listening in from the health unit level, so it won't be your cup of tea. You're not developing guidance, but certainly at more provincial levels or with technical organizations, I think it's really critical to think about taking this kind of approach where you could use the work of other people and adapt that. And the goal really to decrease research waste as a result. So this is a bit how that notion of development happens. You get the information in this software that other people had compiled from different studies and the interpretations, and you actually make new judgments and you say, no, this is a different context here in Ontario, et cetera. And you may end up with different recommendations. And these are just pictures from development with a particular breast cancer screening guideline from another topic that was done. And I think that's really important, along with how we use clear messaging in the guidance that we use, because you'll know through the COVID-19 pandemic, there's a lot of people, maybe not everyone, but a lot of people have become experts in following recommendations and evidence, and the clarity in language use, I think, is really critical. So one of the parts of this project has been looking at plain language recommendations and ensuring that they are readable, understandable for the public. based on the evidence still, but in a way that is really clear what the evidence is for the public. So far we've done quite a number across a number of public health and clinical topics for COVID-19, and this work is still underway. So we take the original guideline document, a recommendation is assessed, and clear, easy to read summaries are written and that meet plain language requirements. And there's actually now an RCT underway on this exact topic, developing plain language recommendations for the public. And then we end up with a version of the recommendation that is in plain language. Here's the overall process that we use with both general public and clinical and public health expert validation. And then that goes and is added to the same recommendation on the RecMap. So what does this all mean? What could this mean to each of you working largely in public health here locally in Ontario? You may want to look at evidence underlying a recommendation or a decision that's made or something that you're trying to put in place. You may want to understand the science a little bit better, and this could be helpful for you. But I also think that we could use this to further the evidence-based decision-making and the trust in our public on decisions. So one of the ways that I want to talk a little bit about that is on some of the work that we're doing here locally. So let's look at some public health recommendations on the RecMap. Again, you can click here to see the plain language recommendation. They're available in 13 languages. And here's an example of one where this example that I'm pulling up is for the primary series for immunocompromised people. And you can see that a bunch of different organizations, including clinical organizations like Canadian Rheumatology Organization, provinces, there's Ontario, BC, and NACI and the CIG have written on this. And largely over time, we've harmonized and ended up at the same recommendations, but sometimes there was confusion and different organizations were saying different things for this topic and many others. So with the RecMap and having guidance there and extracted, what you can actually do is you can see how was that decision made. So here's the Canadian Rheumatology Association summary of findings tables, and you can see the evidence that they synthesized and looked at. So they looked at with 2 doses versus with 3 doses, symptomatic infection rates were lower, and they looked at serological responses and other criteria. And so again, what you can do is you can delve deeper and see the evidence, and it's more transparent how decisions were ultimately made around different recommendations. So how are we going to potentially put that in place and use that? I want to introduce the Peterborough Public Health COVID-19 Risk Index. And what we've done is, many of you will know, when we transitioned to Omicron, case rates, which were the metric largely used in the pandemic until early 2022, were no longer meaningful because eligibility changed, because our capacity for testing was outstripped and significant infection ensued. So the case rate was no longer an adequate tool. So I'm going to talk through this risk index, what it involves, and then how we might link it to evidence so that there can be good transparency and perhaps improve public trust on the evidence that's going into recommendations. So we created this composite index across data variables. We have thresholds for each of the 5 levels, very low to very high risk, case rate, hospitalizations, deaths, PCR % positivity, rapid antigen test self-reporting count, because we still utilize a survey, and residents in our region have been pretty diligent about reporting both positive, negative testing. And wastewater surveillance data goes into this composite index. And then what we have is guidance linked to that. And the guidance is written in the context of current public health response, which is one of individual decision-making and recommendations. But we have basic guidance that's applicable at all levels, including being up to date with all doses that you're eligible for the COVID-19 vaccine, monitoring for symptoms, seeking testing treatment if you're eligible, and staying home if you're sick, and being respectful of the risk tolerance of those around you. And then we have variable guidance that changes at each of the different risk levels. So here you can see for our very high risk guidance, we have a guidance on mask use, social gatherings, high risk settings for the general population and for high risk populations. And so you can see that at very high risk, we're strongly recommending mask use for both of these populations. So what we would like to do now, and we've only just started to get this work underway this year, is to link each of the recommendations that we're making here around vaccine, around monitoring for symptoms, seeking testing treatment, staying home if you're sick, respect of risk tolerance, mask use, social gathering, high risk settings, all those pieces we would like to have linked to plain language recommendations on the eCOVID19 RecMap, so that if people want to know, well, why are we recommending masking, and what's the certainty of that evidence, and what is the effect size of that recommendation, et cetera, you can see pre-appraised guidance that is linked from credible organizations on that. So what we're trying to do now is to identify gaps, because as a result of the screening process, there may be some gaps in guidance that we need to fill and find organizations that have perhaps addressed these topics. And so we're currently underway working on all of that. But the ultimate goal then would be that you would see the recommendation. If you wanted to click and see vaccinated, you could see the recommendation and a plain language recommendation description of the evidence, the certainty, the rationale behind it there. And this whole interface, we hope, will help to not only ensure that our guidance is evidence-based, that we're communicating to the public, but also improve implementation of this guidance as people understand the evidence that is behind it in a more clear, transparent way, and address this implementation gap that we all often see from what is actually being recommended versus what happens in practice. And then ultimately, at the end of the day, hopefully build further public trust that decisions are being made based on evidence. The other really critical piece is thinking in this evidence to decision gap, the implementation gap, about equity. And we will be taking equity into consideration as a key variable in the guidance that we're providing, because when we are telling people to stay home if they're sick, for instance, if we don't have mechanisms for paid sick leave, is that just exacerbating inequities and not actually helping the situation? So how can we assure that equity is a consideration in the recommendations that we're making, and how can we advocate and close some of these equity gaps in some of the guidance? So some of the next steps include key areas we're going to review in the Canadian landscape, so ensuring that we have national and provincial guidance that fits some of the gaps we talked about. We're going to look at Canadian vaccine guidance as one key area, a space to make sure that we can see and track how nationally NACI has given recommendations and how they've been implemented provincially, sometimes differently in different provinces. And we're going to be, as part of this knowledge mobilization work, as part of the project, we're going to be meeting with key stakeholders across a variety of disciplines, with a bit of a focus here in Ontario, because that's where I'm working, but across Canada, to help to look at how this RecMap could be further enhanced and used by the public health community. So certainly we will be reaching out through a number of organizations for stakeholder representation. But if this is something you're particularly interested in helping to talk further about or informing, please just feel free to reach out, send me an email, and I'll be happy to include you when it comes time to set up that workshop. So with that, I will just say thank you to the PI around this work, to some of the key leaders of this work as well. It's been a real pleasure being one of the people on this large team working on this through the pandemic. And I think there's lots of opportunity to continue its use and potentially look to other topics or areas into the future as we try to make more evidence-based health decisions. So there's my handle on Twitter if you want to chat on social media. And again, thank you, Dr. Khan, for facilitating, and for everyone joining. happy to open it up to questions now.
Thank you, Dr. Pickett, for the excellent presentation on RecMap and also the really interesting local example relevant to Peterborough Public Health. So we will now move to the Q&A pod to address some of the audience questions. So please continue to enter your questions into the pod if you have not already had an opportunity to do so. Perhaps while we're just waiting for some more questions to come up, I'll just ask a question of my own. In terms of next steps, I couldn't see in your next step slide whether that was specific to COVID-19 or if you're envisioning this moving beyond, given that we're now sort of facing like multiple other sort of emerging diseases, monkeypox and so on. I mean, I'm just curious if in your next steps focused on COVID-19 or if you're going beyond.
Well, this has been a large CIHR, among other partners, funded multi-million-dollar grant. So it's been a large research project that Dr. Schoenemann's led with some other people from around the world. It's been a huge investment. I mean, I think that certainly it should go beyond. I mentioned the TB RecMap, and there is interest by other groups for other topic areas in looking at this kind of approach. I think it's a really easy way to access information on guidance. So, I mean, I think into the future, it'll become more normalized. The next steps I was referring to here locally are starting with COVID-19 and looking at how we can be more clear about the recommendations that we're making and their linkage to evidence in our local guidance, right? Again, that's largely at a local level in Ontario, linked to, Public Health Ontario or ministerial guidance, but not always. There may be a topic area that's not addressed by local guidance. So how do we find and use evidence? I think this is a bit of a next step in evolution of that transparency for the public, which we know through the pandemic has just become extremely interested in evidence and in understanding this. So hopefully, hopefully we can continue this work beyond COVID into the future, but for the next 6 to 8 months, we're going to be doing some intensive work mapping this out and trying to be as evidence-based and transparent in our methodology for our risk index here locally.
Thank you. In terms of questions from our audience, there was some notes around just, I think in response to the last poll, just noting feasibility as another kind of consideration that perhaps wasn't in the poll. In addition, sort of the flag that certainly the guidance, for some of our audience, they are trying to operationalize the guidance in their public health unit context. So that's sort of being provided by others. So that part may be kind of beyond their control. A question in terms of wondering, since RecMap has been available for quite some time, why has there been less knowledge of its existence, not having seen any links to RecMap on public health sites?
Well, it's a good question. And I think that's why this next phase of this year's grant has been more focused on knowledge mobilization, because I think that the development of the work was a huge piece of work. And many people found out about it. I mean, there's 26,000 users of the website. So there's been large volume use, 179 countries, I think it was, around the world. Folks following WHO guidance would probably be more intimately familiar because WHO's RecMap for their COVID guidance was available, and then and was a subset of this project. But I don't know. I would be interested in people's thoughts on it. I certainly haven't been in the, as one of the people working on this project, haven't been in the province for the whole pandemic. I just moved here, moved back to Ontario in December of last year. So I'm trying to help to do some work on mobilizing the knowledge and utility of it for the public health community in Ontario. But I think there's a bunch of other things. I think one challenge may be if we are having very fast moving guidance and largely at a PHU level in Ontario, we're mainly doing what the province says in updated guidance. If you know, the RecMap can't keep pace with the rapidly evolving guidance, it could be that you know, it's not worth going on to that website and really looking if the guidance you need isn't there. So part of what we've been thinking about is how do you decrease the time from, you know, identification in the search or it being sent to the research team to the extraction, critical appraisal, and it being up on the RecMap. I see another question, how often is it updated? On a weekly basis, there's guidance uploaded. So, you know, it's fairly quick, but keeping pace has been challenging through nearly 3 years of the COVID-19 pandemic. So I think that those are some thoughts, but we're looking to explore why it hasn't been more utilized as part of this knowledge mobilization grant work this year, and hoping that we can increase awareness further. So maybe tell some colleagues, check it out. If you're seeing big gaps, we'd love to hear about them, and we can try to identify some of those gaps. But it is a global project, remember, so it hasn't been focused on ensuring that everything from PHO, for instance, is up there.
Thank you. Another question that relates to updating, but it's sort of the other end in terms of how does this tool remove guidance that becomes outdated? So sort of almost the CQI aspect, like how does it stay current? So I wondered if you could speak to that.
Yeah, so the as part of the search process, when there is an update that meets inclusion criteria found, that's linked, and then the old version is removed. But there's also some ambiguity in this. Sometimes it's hard to tell, is this, you know, replacing old guidance or not, because it's not clearly an update from one organization. So there has been a expert group that meets on a weekly basis and talks about included guidance and talks about the content and searches looks, okay, you know what, this is no longer relevant because of resistance for this one medicine, and new variants have changed, so we need to remove this guidance now. That would be one of the pieces I would say. So guidance is removed on a weekly basis with the update of new guidance being added as well.
Thank you. A question about applicability to our current context, just in terms of are there plain language recommendations for the public for all respiratory viruses and not just COVID, given what we're heading into with a potentially complex fall and winter respiratory season?
Yeah, it's a good thought. It's not been extracted to my awareness yet, though obviously much of the same guidance that's applicable for COVID-19 is applicable for other respiratory viruses, is what I would say. But it's something that I can take note and go back and think about. Certainly, we've continued to be focused on COVID-19 here in Peterborough. I think it's an important transition to start thinking about influenza and other respiratory viruses as they make a resurgence this year. But when we look at the morbidity, mortality of COVID-19, you know, it doesn't compare at all to any pre-pandemic respiratory viruses. It's such a magnitude of difference higher that I think there still is warranted significant attention to COVID-19. So that's been my local approach, but I think it's something to think about as we go forward for sure.
Thank you. So there's a note about the relevance and the interest in sharing the information with medical librarians who could expand knowledge of it, and I guess who could use it in their work.
I totally agree. I think that's a great key stakeholder. What was on our list of key stakeholders, along with MOHs, PHNs, PHIs who are involved in implementing guidance, EPIs, medical librarians, some of the other administrative decision makers. You know, so certainly if you think of other groups that would be helpful to be engaging with, that would be helpful. One project I didn't get the chance to talk about, I have a wonderful MPH student from McMaster University who's doing user experience testing of our COVID-19 risk index. And this is part of that, is understanding clarity in the guidance and clarity for the public. But I think, again, engaging the public and not just assuming that our recommendations are falling on listening ears and people understand what we're saying, but actually evaluating that's important. So that's what we're doing with this user experience testing project.
Another question, speaking to, I think, being interested in when or what sort of future knowledge exchange will look like for this project. So will there be additional webinars? Is it linked to health evidence? That's another platform, I think, what that's referring to.
So if you go to the eCOVID RecMap page, you can see some webinars, I think, including some of the recorded ones previously. Or if you follow them on Twitter, which I think it's eCOVID19, let me double check, but I tagged it in one of these. So if you go find me, you can find it. It is eCOVID19 RecMap, at eCOVID19 RecMap. They announce when there's more webinars, including on specific topics or different aspects. So you can certainly follow along. And yeah, definitely there's more coming.
Okay, and the next question in our chat, and maybe it's the last question that we have right now. So if you do have any other questions, feel free to type them in as we get towards the end of the hour. So thank you for the presentation, and asking whether input for the RecMap is taken from more of the interprofessional and community partners to facilitate the contextualization of evidence across multiple settings.
Yeah, I think that's a great point. I mean, it's really critical. The international team working on it is very interprofessional, including members of the public helping to inform. So that's some of what goes into the prioritization of content. But I think the key point that you make that's really interesting is that contextualization is just so important. And we've, I think, learned that one size does not fit all through the pandemic. And what I think the RecMap and this contracted word development that I was talking to you about, what I think some of this could offer is a framework for systematically thinking about evidence and the recommendations made and the context that they're being made in. And factors may differ. So in one setting or context, the risk of COVID-19 may be different, or the equity or risk factors of populations that are being served may be different. And what I think is really important in this notion of contextualization that's been a big focus of this project is being explicit and transparent about what the factors are that change the recommendation in different settings. Because I think otherwise you end up with an environment where the public and people are left very confused by diverging recommendations. Do this here, don't do that here, inconsistencies, and no understanding other than this black box where decisions are sometimes made of what went into, what came out, and why. So I think that, the principles of this and being more transparent in criteria that inform decisions is important, but also this specific methodology, I think, could offer a lot as we look to, building better evidence-based decision-making and building better trust from the public in the recommendations that were given.
Thank you so much. Perhaps I'll just end with a question building on your last response in terms of how you could envision both local public health, provincial public health, and federal public health working together better in the context of guidance.
Yeah, I think that's an interesting one. And I think it's going to be a messy question, keep working through well beyond COVID and maybe into future health issues, threats, maybe even peacetime, if you will, of other public health issues. Because I think that the explosion of evidence is not just going to be for COVID-19 and will be here to stay. And it can be very confusing with many organizations doing overlapping work. So I think one of the goals of some of this work and into the future is trying to think about how processes, criteria could be aligned. And there is a paper that I'll put into the chat with some of this thinking. And what I wanted to say is that I think that there could be a real opportunity here to align what NACI does and says, what provinces are doing and saying, and local decisions. It's not that you're eliminating one level or the other, but I think actually trying to improve coordination amongst the various levels could be really helpful to ensuring at least the linkage to evidence and some consistency, because right now tremendous work goes in at both the national and provincial level around every vaccine related decision, as an example that we're making, and other decisions, other public health decisions too. And that, I think, is good, but I think we could do much more and answer new and more difficult questions if we divided and conquered a little bit, and then used a process of saying, this is the evidence base, right? So perhaps NACI or the Public Health Agency of Canada has done a systematic review. This is the evidence base. They have a recommendation, but that may look different in Labrador than it would in Ontario, than it would in BC, for a variety of reasons. But contextualizing the same body of evidence, I think, is a good aspirational goal for us to do better evidence-based decision-making, decrease duplication of work, and ultimately, at the end of the day, improve health outcomes.
Thank you. I see one last question as we come to the end of our hour has popped into our question and answer pod. So just to end on this last question, whether you are aware of any plans across public health units to have a common template, such as the risk levels used for Peterborough Public Health.
Well, PHO's led some great work on this with its own work. I think there is lots of conversation happening, and I think there's lots of opportunity to find some alignment. I think it's critical for the public for clarity. So I really hope that happens.
Thank you so much. So as we wrap up today's PHO round session, I would like to thank Dr. Pickett for presenting, and I'd also like to thank everyone who joined us for the session today. You can expect to receive the brief and anonymous PHO round survey for today's session, so please try to complete this to help us improve our programming. And lastly, to access past PHO rounds, presentations, and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.